Good evening, everyone. I am Dr. Bandala Rajan, Assistant Professor in Department of Dermatology. Today, we are going to see about recent INICET exam, November 2022, Dermatology questions recall session. First question asked was, Chromoblastomycosis is characterized by. First, Chromoblastomycosis is a deep fungal infection. We can easily remember that chromo means color. Chromo means color. So, Chromoblastomycosis is characterized by copper penny bodies. Here we can see the options given are sclerotic bodies, angioinvasion, asteroid bodies, grain with fungal elements. There is a slight twist in this question because the copper penny body is also known as medlar bodies or sclerotic bodies. So with this itself we can find out the answer. Here the Chromoblastomycosis is characterized by sclerotic bodies engulfed by macrophages. In this image we can make out there are round to oval shaped copper colored bodies within the macrophages. Other options are angioinvasion, asteroid bodies, grain with fungal elements. Actually, this is the case of Chromoblastomycosis. Here we can see verrucous plaques with the histology. We will make this copper penny bodies or sclerotic bodies. Let us see about the other options. Angioinvasion. Here we can see this is an angioinvasion. Angioinvasion is a special property of mucormycosis. That's why they are having necrotic lesions known as eschars. Next option given was asteroid bodies. Asteroid bodies are seen in a fungal infection known as sporotrichosis. Here we can make out the asteroid shaped body. Apart from sporotrichosis, it can be seen in another condition known as sarcoidosis. In sarcoidosis, two bodies are seen. One is an asteroid body, another is a Schumann bodies. The another option given was grains. Grains are classically found in a condition known as mycetoma. It can be actino or eumycetoma. So in this way, we can easily differentiate the points. So the answer for this is sclerotic bodies engulfed by macrophages, which is other name for copper penny bodies. Now we move on to the second question, which is a patient presented with a papular lesions. What is the histopathological finding in this case? They gave this image and they asked what is the finding. The options given are Anderson-Peterson bodies or Molluscum bodies, coilocytes and Jang cells. First we will see the histopathological image. Here we can make out a bulbous invagination of epidermis into the dermis. It is almost mimicking a cut tomato appearance. If you cut the tomato, it will be multiple seeds in there. It is characteristically seen in Molluscum contagiosum. We know in Molluscum contagiosum, the bodies are known as Molluscum bodies, otherwise known as Anderson-Peterson bodies. So the answer is Molluscum bodies. These are intracytoplasmic inclusion bodies. That thing is very important. Here we can make out this oval shaped purple colored lesions, which are Anderson-Peterson bodies or Molluscum bodies. Next option given as coilocyte, another was Jang cell. Here we can see Molluscum contagiosum is characterized by a umbilicated papules with the HP bodies. Here we can see the coilocytes. Coilocytes are nothing but round keratinocytes with nucleus pushed to the periphery, which is a characteristic feature of human papillomavirus infection. Mainly in skin, it is in cutaneous warts. And the third option given us Jank cells. Jank cells are actually other name of acantholytic cells. As you know, acantholytic cells are commonly seen in immunobullous disorders like pemphigus group of disorders. These cells are characterized by large round cell with a large nuclei, hyperchromatic nuclei, with a peripheral condensation of cytoplasm. So, Jank cell is another name for acantholytic cell, which is seen in pemphigus group of disorders. Next, the third question asked was, White Farrago stain is used for. White Farrago stain, actually it is a modification of Zeal-Nielsen stain. In this, 5% H2SO4 is used as a decolorizer. So in this way, we can easily point out 5% H2SO4 is commonly used for staining of Mycobacterium leprae. So White Farrago stain is used for Mycobacterium leprae. For Mycobacterium tuberculosis, they will directly give Zeal-Nielsen stain. We can remember in this way, there is a White Farrago. It's important to fight to take care of leprosy. Something like that you can remember. Leprosy is a difficult disease to manage because they have more comorbidities, more deformities and all. So it is important or difficult to take care of leprosy. So Mycobacterium tuberculosis is stained by Zeal-Nielsen stain with 20% H2SO4. That is an important point. The next option is amyloid. In amyloid, the main stain used is Congo red. In this, if it is in a histopathological section, it will show a red stain. If it is seen under polarized microscope, we can make out a special finding known as apple green birefringence. It's also a possible MCQ. Apart from Congo red, other stains are thioflavin, T and S. Other than that, stains like periodic acid shift stain, Alcian blue, methyl violet, those stains can be useful. Here, this is the image which showed White Farrago stain staining the leprosy bacilli as pink. To differentiate it from leprosy and TB bacilli are lying singly. These are in leprosy bacilli are in groups, always known as in a clump, that is known as globi, cigar bundle appearance. Here we can make out. Next question asked was, which of the following disease has vesicular lesions? The options given are hand, foot, mouth disease, roseola, dengue. In hand, foot, mouth disease, this is a patient of hand, foot, mouth disease. Here we can see multiple erythematous papules and few vesicles. Here we can make out one. There are some vesicles in the soles also. So the answer here is hand, foot, mouth disease. In roseola, it is caused by HHV, human herpes virus, which is characterized by red macules rather than vesicles. Dengue also characterized by purpura due to thrombocytopenia and red macules and papules. Another important finding note in dengue is which are islands of sparring in the sea of red. Means there will be widespread rash with areas of normal colored skin. That is characteristic of dengue. For this question, the answer is hand foot mouth disease. This is a patient of hand foot mouth disease. It is common in children. Now we need to know something about the infections which may present with vesicular bullous lesions. For bacterial, it is mainly impetigo bullosa, which is caused by staph. In viral, mainly chickenpox and herpes zoster, hand, foot, mouth disease. In fungal, the most common one is bullous tinea pedis. Tinea involving soles may have bullous lesions. In mycoplasma, it can lead to two types of lesions. It can lead to vesicular bullous lesions, or it can lead to target lesions, central vesicle with a zone of pallor, then zone of erythema. In that way, it can lead. The next question is a diabetic patient presented with asymptomatic lesions over the axilla, which showed coral red fluorescence on Woods lamp examination. What is the constitutive organism? Here we can see that coral red fluorescence. If there is a coral red fluorescence, it is due to erythrasma, which is caused by Corynebacterium minicismum. We can remember in this way coral Corynebacterium. In both they have COR. So in that way you can remember this. The other options given are Candida albicans, Trichophyton rubrum and Trichophyton solani. Actually, Candida albicans, Trichophyton rubrum won't cause fluorescence in Woods lamp. Trichophyton solani we will see in later slide. In Trichophyton solani, it will show a dull blue fluorescence. In scalp, it leads to favus, which is an inflammatory type of tinea. Microsporum species can lead to blue-green fluorescence, which cause grey patch type of tinea capitis. These two are tinea capitis. Then Pseudomonas aeruginosa, we all know Pseudomonas is green. Molluscum furfur, it will produce yellow-orange fluorescence. Molluscum furfur is implicated in pityriasis versicolor. Cutibacterium acne will show orange or red-orange fluorescence, which is mainly implicated in the pathogenesis of acne. Apart from infection, some conditions like porphyria can also show fluorescence, mainly in urine and teeth. Due to porphyrin production, they will show red fluorescence. These are very important. The next question asked was sporotrichoid pattern or nodular lymphangitis is seen in all infections except. The first option was Staph aureus, second option was Mycobacterium marinum, third was Nocardia brasiliensis, fourth is Sporotrix schenki. In this, we know in the name itself it is given Sporotrix, which are sporotrichoid or lymphatic spread. So this one is out. In mycobacteria, atypical mycobacteria like Mycobacterium marinum will have sporotrichoid spread, and Nocardia brasiliensis also have sporotrichoid lymphatic spread. So the option left out is Staphylococcus aureus. So that is the answer for this case. Next one is black eschar over the back is due to which of the following? Rocky Mountain spotted fever, scrub typhus, COVID-19, malaria. In this, the answer is scrub typhus, which is leading to eschar at the site of bite. Here, the most confusing options are scrub typhus and Rocky Mountain spotted fever, because we know COVID-19 and malaria doesn't have eschar. Only these two options are confusing. Among the rickettsial infections, only scrub typhus and rickettsial pox, both are leading to black eschar. Rocky Mountain spotted fever don't have black eschar. We should know the common causes of eschar, mainly infectious. In bacterial, cutaneous anthrax has black eschar, and ecthyma gangrenosum, which is caused by Pseudomonas infection in sepsis or immunosuppressed patients. Then scrub typhus. In fungal infection, the most common is mucormycosis, which have already we discussed, which has an angio-invasion property. So it will lead to thrombosis of blood vessels. In turn, it leads to eschar. And some tick and spider bites can lead to eschar formation. In non-infectious, main one is purpura fulminans. It is a cutaneous manifestation of disseminated intravascular coagulation, DIC. The another one is calciphylaxis, which is common in end-stage renal failure patients, in which calcium is deposited in the blood vessels, which lead to thrombosis and in turn eschar. The next question is a picture-based question. The finding is seen in. Here we can make out on the knuckles and in the interphalangeal joints, we can make out erythematous papulonodular lesions. This is known as Gottron's papules. Gottron's papules are characteristic finding of dermatomyositis. The other options given are systemic sclerosis, systemic lupus erythematosus, rheumatoid arthritis. Here the case is very clear cut. There are Gottron's papules, so the answer is dermatomyositis. The other possible questions in dermatomyositis is it has other cutaneous manifestations other from muscle weakness. One is this violaceous rash over the eyelids, which is known as heliotropic rash. Other than that, in the neck, the V area of chest, there is a erythematous macules that is known as V sign. It is known as V sign. In the back, it is in the configuration of shawl. This is known as shawl sign. Sometimes same erythema can be in a thigh. That is known as holster sign. These are the important cutaneous signs of dermatomyositis. In systemic lupus erythematosus, we know the commonest finding is malar rash and the erythematous flocks can be there over the sun-exposed areas. Other cutaneous findings are, here we can see blanching of fingers, which is a Raynaud phenomena. The finger will become blue, white and red with a burning sensation. And the patient can develop chilblains, which is a painful swelling of fingers, especially tips, which is known as chilblain or pernio. These are the cutaneous findings we should remember. In systemic sclerosis, the main finding is sclerodactyly, that tightening of skin over the fingers, and Raynaud's phenomena. And in the face, you can see multiple dilated vessels known as telangiectasias. These are the findings. The next question is, which of the following is not a non-scarring alopecia? The options given are alopecia areata, telogen effluvium, androgenetic alopecia, frontal fibrosing alopecia. Here we should read the question properly. It is a double negative question, like which is not a non-scarring alopecia. So they are asking which is a scarring alopecia, right? So in the name itself we can identify from all fibrosing. Fibrosing means scarring. So the answer here is frontal fibrosing alopecia. Now some small clues for how to divide scarring and non-scarring alopecia. In non-scarring, we can remember like this. All effluvium are non-scarring. What are the effluvium we know of? Anagen, telogen. Anagen effluvium, telogen effluvium are non-scarring. All patterned baldness are non-scarring. We know male pattern baldness, that is known as androgenetic alopecia, and female pattern baldness, female pattern hair loss. These are non-scarring. All effluvium are non-scarring and all pattern baldness are non-scarring. Along with that, alopecia areata is a non-scarring alopecia. In scarring alopecia, we can divide that into various categories like papilloscomas, infections, inflammatory, connective tissue, idiopathic, and other causes. In papilloscomas, the important one is lichen planus related hair fall, which is known as lichen planopilaris. In infection, it is interesting. In tinea capitis, inflammatory type of tinea capitis, such as Kirion and Favus, are scarring alopecia. Non-inflammatory tinea, like gray patch and black dot, these are non-scarring alopecias. In inflammatory conditions, the scarring alopecia is caused by folliculitis decalvans. The name itself, it is visible, decalvans, which is scarring alopecia. Other than that, dissecting cellulitis of scalp. Here the name is dissecting, means all the, you can remember in that way, dissecting means all the follicles will be destroyed. In connective tissue disorders, discoid lupus erythematosus is an example. In idiopathic causes, the main one is pseudopelade of Brock, frontal fibrosing alopecia, those things. Other causes like trauma, burns, those also can lead to scarring alopecia. Next, another question was asked is finasteride mechanism of action. Basically, it is a pharmacology question. Still, finasteride is commonly used in dermatology. I took up this question. Finasteride is mainly used in androgenetic alopecia, mainly in the moderate to severe grades, which helps in the preventing the miniaturization of hairs. Miniaturization is caused by dihydrotestosterone, which is an active product of testosterone by an enzyme known as 5-alpha reductase. This finasteride helps in androgenetic alopecia by inhibiting 5-alpha reductase. So less dihydrotestosterone is produced. So there is a less possibility of hair fall. So the answer is here 5-alpha reductase inhibitor. Finasteride is an 5-alpha reductase inhibitor. Aromatase inhibitors are different from 5-alpha reductase. They mainly prevent the conversion into estrogen. The examples are letrozole, anastrozole, and exemestane. These are the examples. Okay, in this way we can easily remember finasteride is a 5-alpha reductase inhibitor. Otherwise, you can remember F5. That way you can remember easily. Okay, thank you. I hope it was useful for everyone.